palpate along the lateral aspect of the anterior shaft, right? For most posterior medial shin splints, so posterior tibialis, you're going to palpate so that the tibia is flat on this side, and you're going to go just posterior to that to palpate along there, also for shin splints. For assessing the joint between the tibia and fibula, the distal aspect, that joint is called the mortise, okay, where those are together. So similar to what we did for the distal radio-ulnar joint, you will come in and you will squeeze those bones together, looking for joint play, okay? If someone has a high ankle sprain, that will feel bad, right? So a high ankle sprain is when they've actually ruptured the interosseous membrane between the tibia and fibula. All right, so for the foot, we really divide it into lateral structures and medial structures, okay? So, let's see, Gina graciously gave me her sheet so I could follow in order, and I've totally blown it already. To the talus, there are going to be a lot of structures that we're going to palpate on the talus. The trochlea is the articular surface that sits within the mortise. So the only way that you can palpate the trochlea of the talus, go ahead and relax for me, is if I plantar flex col and then go into the mortise, I'm now on the talar trochlea. Okay? So right there is the trochlea of the talus. If I dorsiflex him, the trochlea rolls under the tibia and fibula, and I can't get to the trochlea anymore. Okay. Are going to be right at the MTP of the first ray. Do you remember what muscle the sesamoid bones are in?
Adductor.
It's going to be flexor talus brevis. Okay? So that's going to be that short muscle that goes across the bottom of the foot. Sesamoid bones can get fractured if you have someone who has turf toe, so their toe gets stuck way up. They might also have a concomitant sesamoid bone fracture. Okay, so that's common to have palpate until you feel it contour out. That's going to be important because that'll be a landmark for subsequent tarsal bones. Okay, the same for the fifth metatarsal. What muscle attaches to the base of the fifth metatarsal? Fibularis brevis. Yeah, so fibularis brevis. So on all of us, that's going to be a pretty big bony prominence, and that's pretty easy to find. When you come, we'll go ahead and go to the lateral structures. I think we're okay to do that. If you come just proximal to the base of the fifth metatarsal, there's going to be a hollow there, and that's when you're going to be on the cuboid. Okay. Now on the lateral ankle, what's the set of ligaments on the lateral ankle? Okay, so there's three. So there's the anterior talofibular, so it's going to go from the fibula to the talus. We're going to have the posterior talofibular. That's all right.
No.
You're good. Okay, and then in between those two is going to be the calcaneofibular ligament. Okay, so we have the anterior and posterior talofibular ligament, and then in between those two is going to be the calcaneofibular ligament. So when you have someone with a lateral ankle sprain, most often, although not always, they're going to tear their ATF first, then their CF, and then their PTF. So they're usually going to go anterior posterior. On rare occasions, you can have someone who blows out their PTF first, but I can't think of a scenario where I've had anyone blow out their CF first. Okay? So you'll want to be able to palpate. These are not ligaments that you're going to be able to feel necessarily under the skin. So you're palpating just around the distal aspect of the malleolus, just looking for reproduction of symptoms. Okay. Now there's also a bony landmark on the calcaneus, which is the peroneal tubercle, and that's going to separate our peroneal muscle group. Okay, so you can palpate it there. There's also our extensor retinaculum. Some of you have dissected that really beautifully on your cadavers. We have the superior and inferior aspect of the extensor retinaculum, right? the extensor retinaculum will come across and go across the peroneal tubercle, so people can actually develop a compartment syndrome distal to the peroneal tubercle. So it happens more in women, and so they may have to have a release of their extensor retinaculum off of that peroneal tubercle. Okay, so the peroneal tubercle is going to be that bump. It's going to be pretty prominent in everybody, just inferior to the lateral malleolus. It's right there. Okay. Are there any other lateral structures? I guess I can look at your sheets. So lateral, talus. Okay, so the sinus tarsi, we are going to be looking for subtalar neutral, and that's an important position on the lateral side. If you come just anterior to the lateral malleolus, again, there's going to be a small dip. You're going to be on the head of the talus in the sinus tarsi. Okay? So that's this spot here. When we palpate for subtalar neutral, we're actually going to put our hands on either side, and then we're going to move the rear foot to try to see if the talus is centered between our fingers. You'll know you're on the talus and not on something else when, if you invert and evert the rear foot, you will feel that talus. It's bulging on my middle finger, and it's hidden on my thumb, and then when I come this way, it pokes out at my thumb. If you're too distal, you move that rear foot, and you're not going to feel it go away. So it's a good way to know that you're on the talus if when you invert and evert, you can feel those movements. Okay. Of her ligaments, I would also be able to do my distraction with her in this position. So I would actually do all of my ankle exam with me in this position. Okay?
So that's what you want to see.
Right?
Are we doing like
No.
a massage?
Yeah. So I'm only showing you this because the question came up of how would you actually do the exam. So we talked about to find the cuboid, we come off of the base of the fifth, going to come down to the base of the first metatarsal, and then that first bone is going to be the medial cuneiform. Now for the second one, I'm going to follow the metatarsal down. So now I'm on the middle cuneiform. And now I'm on the lateral cuneiform. So your best landmarks for the cuneiforms are going to be the metatarsals. Okay. We had talked about the retinacula before. The dorsalis pedis, you're going to come up between the first and second ray on the aspect of the foot. You have a lovely dorsalis pedis. Nice. Okay. So that was plantar fascia. We did dorsalis pedis. We did the cuneiforms. So I think we're on to the medial structures. Inferior, we're going to be on the medial tubercle of the talus. Okay, it's not nearly as pronounced as the peroneal trochlea is on the other side. If we go straight down and then come back up, I'm on her sustentaculum tali. Okay, so I went directly inferior to her medial malleolus and then hooked around and came back up. I'm on her sustentaculum tali. It's an important structure because we have a couple of ligaments that are attaching there. Okay. Now we also talked about the head of the neck of the talus, and that's going to be right here. Okay, so you're going slightly anterior to the medial malleolus. The deltoid ligament, again, is going to be this triangle shape just distal to the medial malleolus. It's again a structure that you're not going to be able to palpate specifically. You're looking for reproduction of symptoms. Okay. Now, if you're palpating the deltoid ligament and you tell me that you're palpating for reproduction of symptoms, and I say, okay, the person has symptoms, what is the next test? What is the next test that will stress the deltoid ligament? Whatever her name is. Yes, so you could palpate attachments. What else? Eversion. Okay. And would you do active range of motion or passive range of motion?
Passive.
Passive. because it's a non-contractile structure. That would be the best test. Palpating attachments is also considered one of the best tests. Okay, if you tell me that you're going to do flexion or extension, or if you tell me you're going to do active range of motion, that's a fine test. It's not the best test. Okay. Okay, so if we come down, we're going to be on our cuneiform. And there is your navicular tubercle. Okay. In a lot of people, particularly people with flat feet, it's going to be the biggest prominence on the medial side of the foot. Now, what are the attachments for the spring ligament? Navicular tubercle and the substentaculum tali, where we just were. So if I go in between those, I can palpate the spring ligament. Okay, so navicular tubercle, spring ligament, and then the posterior tib pulse is really a bear. You're going to come posterior to the medial malleolus and slightly superior, and you're going to press against the tibia and try to find the pulse. And the posterior tibial artery, okay, so for Jenna, it's further inferior than it would where I would normally try to find it, which would be up here. So I just had to slide down. So what you'll have to do, it's very variable among people. So you're going to take a, 4 inches, and you'll have to go up and down the tibia, pressing against the tibia lightly to try to find that pulse. And you're pressing against the posterior